How effective is Propofol as a sedative? What do you need to know as a nurse when administering Propofol? All of that and more, so keep on watching. Welcome back to NurseBrain. My name is Neil Bryan Galve, and for today, we're gonna have a thorough nursing drug study regarding your Propofol. If you haven't watched the nursing drug study I created on my channel, which there's I believe hundreds of them, please do so, because I'm pretty sure that you'll be able to have a reference on the most common medications that we actually use in the area. You guys ready? Let's go! Let me share to you the objectives for our today's lecture. We're gonna answer the question, what is Propofol? Classification, mechanism of action, and dosage. We're gonna have the indication, contraindication of administration of Propofol, adverse reaction, and of course, this will not be a nursing drug study if we're not going to discuss about your nursing responsibility. Now, let's begin. What is Propofol? Now, Propofol is an intravenous anesthetic used for procedural sedation during monitored anesthesia care or as an induction agent for general anesthesia. It may be administered as a bolus or an infusion or some combination of the two. Next, classification, mechanism of action, and dosage. Drug class. Propofol belongs to GABA A receptor agonist, sedative, general anesthetic. Nurses, what is GABA A receptors? A GABA receptor agonist is a drug that is an agonist for one or more of the GABA receptors, producing typically sedative effects and may also cause other effects such as anxiolytic, anticonvulsant, and more of muscle relaxant effects. There are three receptors of gamma aminobutyric acid. Mechanism of action. The action of Propofol involves a positive modulation of inhibitory function of the neurotransmitters gamma aminobutyric acid or GABA through GABA A receptors. Now, what is gamma aminobutyric acid or GABA? GABA is the main inhibitory neurotransmitter in our brain, stopping chemical messages from passing one nerve cell to the nerve cell. Now, let's talk about your dosage. Now, I kind of separate this in few different parts in terms of how Propofol is being used. So please be mindful, okay? Now, in terms of induction of general anesthesia, you can give Propofol from 2 to 2.5 milligrams per kilograms IV, administered at a rate of 40 milligrams, Q 10 seconds until induction onset. Maintenance of general anesthesia. That's another use. We have 6 to 12 milligrams per kilograms per hour IV. Surgical diagnostic sedation. Now, like I said, Propofol is being used in different forms and in different ways. So the way I manage the dosing is that I kind of categorize it or put it I categorize it in a way where they are being used or what they are being used for. All right, so if you're gonna use Propofol for surgical diagnostic sedation, here's the dosing: 0.5 to 1 milligram per kilogram over 3 to 5 minutes, followed by 1.5 to 4.5 milligrams per kilograms per hour for continued sedation. How about for maintenance of ICU sedation? Now, you will see this a lot of times in the critical area. Propofol is being used as one of the sedatives. It's either we're gonna do a bedside procedure intubation, or we're gonna have colonoscopy or bronchoscopy or whatever it is. Propofol is actually being used in the ICU. But for maintenance of ICU sedation, here's the dosing. It depends on your SOP. We have 0.3 milligrams per kilograms per hour, increased by increments of 0.3 to 5 milligrams per kilogram per hour, Q15 until desired level of sedation and target VAMAS is achieved. Maximum doses 5 milligrams per kilogram per hour. Higher doses have been associated with Propofol syndrome. Take note. Now, this may be administered boluses of 10 to 20 milligram to rapidly increase sedation in patients not prone to hypotension. May need to decrease dose by 20 to 30% in elderly, debilitated, or hypovolemic patients and refractory status epilepticus. We also have 1 milligram per kilogram, additional 1.2 milligram per kilogram boluses every 3 to 5 minutes until clinical response to a maximum of 10 milligrams per kilogram. Now for continuous infusion, Propofol, you can start it with 2 to 4 milligram per kilogram per hour. If seizure control is not achieved rapidly, another agent should be added. Remember that you can use Propofol in combination with the other sedatives. Decrease infusion gradually to prevent rebound seizures. Now, the way you kind of like wean off the patient or off sedation, the way you're gonna taper it, or not abruptly, you're gonna kind of like taper the patient out from Propofol gradually, meaning you will lower the dose. Now, what are the indications? Why do we give Propofol? Now, for short-acting general anesthetic agent, low doses may be used as sedation of intubation, mechanically ventilated patients. Short action useful for patient where rapid reversal is desired, example neurological injuries. Now this may provide some cerebral protection as well. Now, Propofol can be used as status epilepticus for refractory seizures. Bronchodilator properties of Propofol may be useful in treating a status asthmaticus. Now, what are the contraindication? Meaning, when is the time that Propofol is not indicated, or you will not give Propofol to your patients at all? Now, do not give the patient allergic to soybean oil or egg phosphatide. Continuous infusion for greater than 24 hours is not recommended for use in patients less than 18 years old of age. Now, nurses caution. Now, has not analgesic properties, administered concurrent pain relief as required. Now, nurses, what are the adverse effects? Hypotension, myocardial depression, bradycardia. Treat bradycardia asystole with atropine. Arrhythmias, flushing. Apnea could be one. Use only with mechanical ventilation or during conscious procedural sedation. Anaphylaxis, anaphylactic or anaphylactoid reactions, cough. Elevated triglycerides. Excitatory phenomena, for example, spontaneous musculoskeletal movements and twitching and jerking of hands, arms, feet, or legs. Now, adverse reaction involves headache, dizziness, agitation, anxiety, confusion, hallucinations, disinhibition upon awakening. Nausea, vomiting, abdominal cramping is also one of the adverse effects. May discolor urine green. So remember that we have Propofol syndrome, na metabolic acidosis, elevated lactate, hypotension, cardiogenic shock, hyperkalemia, rhabdomyolysis, lipidemia, renal failure, ST changes or arrhythmias, so on and so forth. There's also a risk for torsades de pointes or TDP. Propofol should only be rarely, if ever, be given to patients with congenital long QT syndrome or yung tinatawag nating CLQTS because the danger is clear. However, when there's no alternative safe drug is available and the illness is severe, some patients with CLQTS may be treated with Propofol by physicians with expertise in the treatment of arrhythmias. Now, this is the exciting part. What are your nursing responsibilities? Listen up. When it comes to administration, nurses, you have to infuse undiluted. If there is a need to dilute prior to administration, use only dextrose 5%. Do not dilute to a concentration less than 2 milligrams per ml. We give Propofol as it is. We don't dilute it. So if you will see a Propofol, it's normally looking like milk in a big vial. You open it up, you will aspirate, depends on your hospital SOP, you will aspirate it and put it in a clear bag and you don't dilute it with anything. If so, it's only compatible with 5%, okay? Now, do not use if evidence of separation of the emulsion. Discard any unused portions. Must change IV tubings and bottles Q12 hours when running as a continuous infusion. This is true. Continuous changing of IV bottles and infusion is very much important, especially when you're working. Well, this medication is only given, I've only used this in the critical area, so yeah, you have to change the IV tubings regularly. Maintain strict aseptic technique during handling as vehicle can support rapid bacterial growth. Should be weaned off to prevent rapid reversal of sedation. Now, for patients who require an air venting filter, use a 1.2 micron filter. To Propofol will plug a 0.2 micron filter. Now, drug interactions. Now, nurses, I want you to be mindful of your drug-to-drug interactions. Propofol plus narcotics equals may increase propofol effect. So normally, we have propofol and then we have fentanyl or midazolam. It's a combination because it enhances the effect of propofol. Propofol plus other sedatives equals may increase propofol effect. Monitoring therapy. Nurses, here are the things that should be always part of your nursing assessment every time you have a patient who is going to have or is having continuous infusion of propofol. What are the things that you have to check? Respiratory rate, oxygen saturation, blood pressure, ECG rhythm and ST changes, response to sedation, delirium screening, blood gases. Normal blood gases is being taken. It depends on the doctor's order. Lactate, triglycerides, cholesterol, liver function test, renal function, adult critical care protocol. Now, be mindful that this may be administered by IV infusion by a nurse in adult critical care. Now, may be titrated by a nurse in adult critical care. I've never seen propofol being given in the ward, only in the critical area, ICU, CCU, those things. Continuous infusion might be administered by infusion device and the pump library must be enabled. Do not free flow, for the love of God, propofol. It has to be with the infusion pump. Okay, now most infusion pumps, they have this data set. You have to find the proper settings for propofol. Propofol is indicated for continuous sedation during invasive mechanical ventilation or for short-term procedural sedation. Discontinue propofol when patient is no longer mechanically ventilated. Of course, what is the use? Or at the conclusions of a short-term procedure. If you like this content, please see these related videos. Till next time. Once again, this is NurseBrain, inspiring greatness one lesson at a time.